Welcome to the Sports Docs podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
And on each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
On today's episode, we're focusing on post-op rehab after shoulder stabilization surgery with Dr. Yoni Rosenblatt, a physical therapist at True Sports Physical Therapy in Baltimore, Maryland. We have some really great articles for you that contribute well to our conversation on shoulder instability rehab. As always, links to all the papers that we discuss on the show can be found on our podcast website, www.thesportsdocspod.com.
All right, so we'll start off our discussion today with an article from the Journal of Sports Rehabilitation in October 2019 titled A Clinical Comparison of Home-Based and Hospital-Based Exercise Programs Following Arthroscopic Capsulolabral Repair for Anterior Shoulder Instability. That's a mouthful.
Yes.
This prospective study evaluated 54 patients who underwent shoulder stabilization surgery followed by either a home-based PT program versus a hospital-based PT program starting 4 weeks post-op to 6 months post-op. And while they didn't report range of motion in the study, the authors did report no difference in patient-reported clinical outcome scores at any time point in the recovery. The authors concluded, therefore, that use of a controlled home-based exercise program is as effective as a hospital-based rehab program after shoulder stabilization surgery, but more on our thoughts on this in a little bit.
That is a mouthful. I'm so glad you give me easier parts.
I try.
All right. Then from JSCS last month, we review an article titled Cross-Education Effects on Shoulder Rotator Cuff Muscle Strength and Function After Shoulder Stabilization Surgery. This randomized controlled trial included 28 patients who underwent arthroscopic shoulder stabilization surgery. Patients were randomly assigned to standard rehab with or without the addition of cross-education. The cross-education group received isokinetic training with the non-operated shoulder, focusing on rotator cuff muscles. At 6 months post-op, patients in the cross-education group demonstrated significantly greater cuff strength, but functional outcomes between the groups were totally equivalent. The authors suggest that cross-education may improve dynamic shoulder stability, but not the functional capacity.
We wrap up with an article from the 2022 issue of IJSPT titled The Effect of Blood Flow Restriction Therapy on Shoulder Function Following Shoulder Stabilization Surgery, a case series. This study included 20 military cadets who underwent shoulder stabilization surgery and then completed 6 weeks of upper extremity BFR training beginning post-op week 6. And while there was no comparison group, the authors did report significant and clinically meaningful improvements in shoulder strength, self-reported function, and upper extremity performance following BFR training.
We are joined today by Dr. Yoni Rosenblatt, a physical therapist at True Sports Physical Therapy in Baltimore, Maryland. Yoni received his bachelor's in kinesiological sciences from the University of Maryland in College Park. He went on to complete his doctorate of physical therapy at the University of Maryland in Baltimore. Yoni has received numerous additional certifications, including the Selective Functional Movement Assessment, a Certified Strength and Conditioning Specialist certification, and an Orthopedic Certified Specialist, OCS. He is also highly skilled in manual therapy and advanced dry needling techniques.
Yoni is the director of sports medicine for Israel's national lacrosse team and is a physical therapist for the Israel national baseball team competing in the 2017 World Baseball Classic. Yoni also hosts his own sports medicine podcast, the True Sports PT podcast, which you should definitely check out for all sorts of rehab tips and tricks. Welcome to the show, Yoni. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org. Welcome to the show, Yoni. Thank you so much for taking the time to join us today and share your expertise with our listeners.
Excited to be here.
Awesome.
Yeah, we're excited to have you.
Absolutely. So before we dive into all your tips and tricks for your patients that you see at True Sport PT, we wanted to talk to you about the utility, if any, of home-based PT for shoulder instability rehab. So in the aftermath of the COVID pandemic, I'm sure you've seen this, Catherine, you've probably seen this. There's been a surge of home-based PT programs and phone apps that promise to allow patients to recover from their orthopedic surgery in the comfort of their home. I'm personally really skeptical about this, especially for shoulder surgery, but I wanted to get your thoughts. So our first paper looked at this. They compared a hospital-based PT program to a purely home-based PT program. And while they didn't measure range of motion at any time point, which I think is a big flaw, they did report that clinical outcomes were equivalent at all time points. So what are your thoughts on this? Would you ever recommend a pure home-based program after shoulder stabilization surgery for anyone?
So this is near and dear to my heart because I was a part of a startup which really pioneered this home exercise specifically for shoulders. And offerings on the market today, we had an exit from that startup. So offerings that I know of currently today are subpar, and they terrify me personally. To trust a patient to a home exercise program. Here's why. Especially in my world, I live in the sports world, and so I'm dealing with a lot of overhead athletes, active individuals, and if I had a nickel for every time a patient came in to see me and said, I started this other PT and now we're coming to True Sports, multiple sports. And I said, let me see what you're doing. I don't know why it didn't work out wherever you were, but let me see what you're doing. And they're doing the right exercises. They're getting all the right answers to the test, but their form looks like crap. They don't know what their shoulder blades are doing. They don't know where they should feel it. No one's cueing them. No one's changing it. And with a few little tweaks, all of a sudden the home exercise program is far more effective. I think patients need that. Even the elite population needs that. They don't know what their scapes are doing, especially post-op. So it's great that study supported favorable outcomes. It's bananas that they're not looking at range of motion. There are really good technical ways to measure that virtually. So that should be a piece and was a piece of the program that I created. But nevertheless, no, I don't love it. One, it's going to put me out of business. But two, there's no way in hell the patients know what's actually transpiring. And if you're dealing with an active population, the shoulder doesn't just need to be okay. It needs to be awesome. And I think you need a skilled set of eyes for that. I'm biased, but that's the way I feel about it.
Yeah, no, I think, I'd be shocked if we're not all on the same page. So full disclosure, I use an app occasionally, not with all my post-ops, but it just is a range of motion check. I only use it with knees. And it basically is like a home monitoring to make sure they're staying on track. It's not it's a supplement, or I should say an adjunct, where it lets me know it. I get a trigger sort of email if it says they're really behind. Or it can also say I'm having a lot of pain. It'll send an email to the office if they're rating their daily pain at 7, and I don't expect it to be there. But literally all it's really feeding back to me is they have, full extension in their knee, or they get to 95 or whatever. And if someone is farther out from an ACL surgery, and I'm they should be way ahead of that, then I can just call the person and say, have you been going to your PT? That kind of stuff. But it's not a replacement. So I think, there's some, you can argue there's some needs for say rural populations or things like that. But I certainly think, first of all, I can't believe they didn't do range of motion. I just don't understand that. But yeah, I think we're all on the same page there.
I think that makes a lot of sense. One more little tidbit. I'm a little bit obsessive with home exercise prescription and programming. We have a proprietary app that True Sports uses. And this is just a build out of what I used to do when I first started my practice. I would just video my patients and text them a video of them doing the exercise and me narrating and coaching behind it and send it to them. And all I did was make that an indwelling app. So every single patient that walks into True Sports downloads the app. They have access to their home log, which is them doing the actual exercise in their evaluation or in their reevaluation or whenever they're getting it. And then I program reps, sets. They'll shoot me a text inside the app, say, hey, this is easy, this is hard. And I can manipulate it inside. So long gone are the days of the printout.
Yeah, the ditto.
And I think it's so really, I would say lazy of the therapist if they're not providing real specific home exercises to that patient. And every single, especially the shoulder, is different. And so you got to coach it a little bit differently. And so just using the app, even if you're going to either contact us and you can white label our app, or just use your freaking iPhone and put some effort in to give your patient a very specific home exercise regimen.
Okay. So I feel like right before we started recording, you were like shocked that I do the editing for this. So but like you can make an app.
You can make it. Yeah. I can pay someone to make an app.
Okay.
Yeah.
I was like, how are you making this? Like,
Yeah, I'll show you that afterwards. It's great.
Okay.
Awesome.
So,
So I think,
go ahead.
yeah, go on. No, you go on.
I was going to say, so that was, I think, we see like maybe there's a little utility for, maybe making some measurements or doing some like remote monitoring, but like, obviously like, there's some things that we're seeing are like big red flags as far as like, they really need to be in a formal facility-based program. I don't know if Ashley, you have anything else to like, add on that study or.
Yeah, no, I completely agree. I echo everything you guys said. I think that the fact that they didn't measure range of motion is a big deal. And also for me, I mean, I have very specific range of motion parameters after an arthroscopic Bankart, like how I progress. It's very specific degrees week by week. And so I don't necessarily trust the patients to know what those degrees are. Like even if they are putting in the work and doing everything diligently, I don't know that I can protect them from themselves not doing something too much that maybe they shouldn't be doing, stretching external rotation too much after I've done a repair. So I think I just feel more comfortable having a licensed professional that's dedicated their lives to learning how to do this with their hands on my patients rather than my patients trying to figure it out, even with a great app. Like Yoni, I'm sure your app is great, but I think that having someone evaluate and be hands-on is really important. So I think we're all saying the same thing here.
It is important. I'll tell you where I do see some utility. And what I'll do is I'll have patients come in and see me pre-op.
Yeah.
And I will teach them the exercise while they have a decently functional shoulder, but to show them very simple things that will transpire in the sling. Now, we're going to get into this, I think, a little bit later as to how quickly I see these patients post-op. I would love to see them as early as possible. And you guys, being the medical community, is so freaked out that I'm going to mess up your repair. But I'm telling you, we're not. We're not going to mess up the repair if we have half a brain. But I will record those exercises that I want them doing for the first 4 weeks. If Dr. Murthy is crazy and he won't let me see them before the first 4 weeks, then at least I have taught them those exercises prior. They have film of them doing it and my nasal voice in the background. There is some utility there I could see with them using the app and making that the home exercise program. But once you need to start progressing range of motion or handle the millions of questions that come up, I love seeing them in office, obviously.
Yeah. So what I always tell people, say I operate Tuesdays and Thursdays. If you have surgery on Thursday, I want you in PT on Monday. If you have surgery on Tuesday, I want you there either Thursday or Friday. You know what I mean? So it's like, I want them there quickly, and obviously like I'm, telling them where I'd like them to go to PT. So it's all people I trust and stuff. But I think there's a ton of value in just like even them just like getting some anxiety down and realizing, oh, it is okay. It's not so scary when I take off my sling and I, do all these kind of things. Otherwise they're sitting at home and they're all freaked out. And like, I think there's, with obviously I trust the people I send them to make sure that they're doing a good job. But then I also think it just helps reduce a lot of their own anxiety.
Is
I
that
completely
because
agree.
you have a background in physical therapy, maybe? And you trust us or no?
Possibly.
Okay.
But just like anything, right? Like there's good doctors, bad doctors. Like it's not like I'm like, oh, go, I don't know, here's a sheet, go pick a physical therapist. Like all my patients will tell you that when we're talking about surgery, I'm like, where do you live? And they'll tell me, and I'll like really pinpoint, like, okay, what insurance do you have? Okay, I want you going to see this place, and I want you seeing one of these 3 therapists. So it's definitely very like dialed, but that, just like you wouldn't say, I don't know, go to any surgeon you want. You would sort of say, I know this surgeon has great outcomes, or I see their patients and they do well, or, maybe skip that office. I think it's just like anything else.
Okay, let me ask you this, and this question goes to both of you. I know you're supposed to be asking the questions and I'm supposed to be answering them, but is there any pressure from Dr. Bassett? I think you're in private practice, Dr. Logan, private?
It's private, yeah.
Private. So is there any pressure to keep them in-house with the PT that you guys offer?
No.
No qualms about it?
So for me, I'll just say we don't have our own PT. We refer to PTs, but there are certain PTs that we're linked with. Like if we do community outreach, we tend to do a community outreach with a certain PT group that we just have a great relationship with. But there are certain areas where there's a stronger PT at a different company in that area, and that my other PT knows I'm going to send to them. I'm not sending to a company. I'm sending to the physical therapist that is working with that patient. If that PT is excellent and has yielded excellent outcomes with my surgical patients, that's where they're going. I don't say no loyalty. That sounds terrible, but my loyalty is to the patient. So it's wherever they're going to have the best outcome personally.
Yeah, I think, there's PTs obviously like in my building, or PTs that, at the hospital. My clinic is in a hospital. So, but, I just think there's different strengths. And so one, like it has to be convenient for the patients. That's why I always talk about like, where do you live? I want it to be somewhere that's in network for them. And, but I think there's also a little bit of matchmaking. So just because so-and-so is good with knees. Maybe like I just sort of intuitively know like they're better with like an older population, or better or I know this patient is super anxious. They need somebody who like knows how to work with that and get them on track. So it's that extra step, but I think it's a little bit of that matchmaking. And anytime I've sort of had a contract, like with, working with a hospital, like they will always bring that up. Oh, we have PT on site. I just want to let you know, and you can do this and you can do that. And I, very quickly say like, that's a really important decision. And that's always going to be my decision. Maybe they are great and maybe I will, but
but maybe they're not. I love that. I hope all the docs that are listening to this heard that and we're taking notes from that, because we love that. That's great to hear.
And honestly, Catherine, I think you made a really great point. And Yoni, I think you were getting to it too about when people start PT after. So recently I've become more aggressive in terms of getting people in. So we've talked about ACL management. So I usually see them post up day 3. I do a dressing change, I drain them, and if they need to be in, then I get them into PT that day. So I thought I was like, great, getting them in post up day 3. I have a surgeon in my group who does post up day 1. Before he sees them, get them in. And even like the mental side, like they come into clinic, they like crutch super quick, hop up on the table. They're just like, they're not afraid. They're not guarded. It doesn't take them like 30 minutes to get out of the car. They just are just functioning better. They're more comfortable in their own body. I think because someone's like helped them, even just like getting on and off a table and crutching. And so I feel like with everything, I'm becoming more aggressive with early PT. And I feel like Bankart's probably about to follow that. I don't send them immediately after a Bankart, but I feel like I'm heading in that direction because of what I'm seeing in other areas. So I think that's really important.
And I would encourage you, if in all of your guys' spare time, to take a look at some of the PT literature. And it's really strong in supporting early PT for all types of shoulder interventions, whether it be soft tissue or whether it be a bony block, where not only are we not ruining things as PTs, but that patient, like you said, their pain levels come way down as soon as they start PT. It's that 4 weeks that is absolute hell when they're living in that sling. They don't know what to do. No one's answering questions, and no one's moving the shoulder. And don't forget, like all the little things we do, like muscle recruitment and scap recruitment, that's not touching your repair. It's only helping the patient. So I love to hear that you're getting a little bit more aggressive.
Yeah, absolutely. Well, also,
Go ahead.
Oh, no, I was going to segue into our next one. So if you have more to add on this, go do it.
No, just repeating stuff. So
it's cool. This is such a good conversation. Yeah. Awesome. So I feel like that really lends kind of really well into our next thing we want to talk about, which is the other things you can do besides moving the shoulder, right? So it's not just the operative shoulder, it can also be the non-operative shoulder. So part of this podcast we like to do is we really like to highlight the newest literature. And part of doing that is doing a literature search in anticipation of our episode. And we came across this paper in JSES from last month that talked about cross education. So before we dive into the results of that, can you tell our listeners what cross education is?
Yeah, I'll keep it really simple. It's working out the contralateral limb. So you have surgery on your right shoulder. You have surgery on your right shoulder. It's doing exercises with the left and seeing how well that can affect the right.
Yeah.
Awesome.
Yeah, and I think not. My guess is like if the surgeons that are listening are like, what's that word? You know what I mean? Like,
yeah.
But it makes a lot of sense because there's like also that data about BFR that you get those cross benefits. Like, you're doing BFR on the right and somehow it's helping the left. And, so it makes a lot of sense just like neural network wise that these things are occurring on both sides. And I would also just think like mentally, like, because I never really talked to my patients specifically about like cross education, do this on the other side, and this is going to have a benefit on your surgical side. But I always talk about like in the pre-op sort of time, like, I want you going to the gym as soon as you feel comfortable. Like just because you had knee surgery doesn't mean you can't like sit and do like rows or, like have somebody bring weights to you and do like upper body or core or something like that. Just mentally, you're just going to feel a lot better. But, I would imagine that there's like just some mental benefit to that too, just feeling like you're moving. But I don't know like what you guys think about that.
I mean, I think there's a huge amount of mental benefit, just getting people back into the routines. When we talk about BFR and putting that on contralateral limb, and we'll get into this with our BFR conversation, that's really most likely a systemic response and a hormonal response where you are getting significant amounts of release of human growth hormone by working with a tourniquet on your limb. Now, that's going to help the contralateral side. But I would also say there is no harm in putting it on the affected side when we get into BFR. I would also say when we talk about cross education, that I really stipulate for homework. Like a patient comes into me and spends 45 minutes with me. I want to spend as much time as possible on the affected limb. So I'm not going to have them do those things in office. And when I do work bilaterally, especially lower extremity, but also upper extremity, they are going to live on their unaffected limb, right? So if I'm asking them to do a row, if it's not individually harnessed, they're going to use the strong limb no matter how hard they try not to. So I'm going to shy away from that. I'm going to live unilaterally as much as possible, even doubling down with electric stim to enhance muscle recruitment and things like that very early and really emphasize, hey, there's so much you can do with the affected limb. That's where I want to spend my time. In terms of the cross education, we know it works. It's very neurally driven, right? So you're going to increase your neural drive and you're just going to have more neurons that are activated. And so your brain's going to be able to control the affected limb a little bit better. In terms of hypertrophy and strength, it is about 50% effective as loading the affected limb. So as soon as I'm able to put a load in that affected limb, you got to live there. We're not going to make our money and you're not going to make as many gains as possible by living just with this cross education. You got to be quick to get out of it. By the way, I would say you got to be quick. That was a good sound effect. You got to be quick to get out of BFR also. So as soon as you can load heavily, you're going to get far more activation. You're going to get tissue response by creating load. So you just want to be careful that all of your sessions are not limited by that tourniquet cutting off blood flow. Just food for thought.
Can you expand a little bit on that? Because here I'm thinking, I'm not PT trained, that always operating under lower loads with less strain through the tissue, let's say ACL, I know we're talking about shoulder, but like less strain through a ligament that we're trying to get to ligamentize and heal in would always be a good thing if you're working the muscles under less stress. But you're saying that no, at some point you reach a point you want to actually stress them with a higher load?
Yeah, there's no question. I mean, that's where we see benefit. That's where we see an increase in robustness of tissue to be able to handle those loads. And you're cheating the patient from making those gains by living in that high rep, low weight environment, which is necessary in the blood flow restricted environment. So you want to make sure as soon as that tissue can tolerate load, you are progressively loading it. And true for the ACL as well. I mean, there's so little load that transpires through the actual tendon, which you're asking to become a ligament, unless you're cutting, that we're really talking about muscle tissue and tendon tissue, and you want as much force as the patient can tolerate productively, because that's going to lead to gains down the road.
Yeah, makes sense.
Can I ask one more question about cross education before we move on further to talk about BFR? So if I'm telling a patient, here are things you can do at home, because you mentioned it was primarily home-based, what kind of exercises specifically are you having them work on? Is it mostly cuff? Is it mostly periscapular? Like what's kind of a program that you give to them?
Because the effect of cross education is so neurally driven, it's going to be more of my isometric holds and prolonged holds. So I would apply that to everything you just mentioned. Cuff, scap, live in the ISO world, that you're going to see better carryover. It's actually amazing, and you can prove it to your patient by saying, okay, let me see you do your right side. Let's say that's the affected limb. Try an isometric ER. Where do you feel it? Okay, now let's do a couple reps on the left. Where do you feel on the left? Oh, you feel it in your scap. Great. Let's go back to the right. All of a sudden, they feel it in their scap. It produces buy-in, but it's purely neurally driven.
Okay. Great. Thank you.
Well, let's dive a little bit more into the BFR since we've already kind of touched it. And I think it's one of our favorite sort of side topics. So we also, for our listeners, we did do a 2-part episode with Eddie Chang. Do you know Eddie Chang? Because he's like in your mid-Atlantic.
No, but I got to get him on the podcast. Where is he?
He's at Inova.
He's at Inova. I love Inova.
Yeah.
I love Dr. West. There's no one better.
Okay.
Yeah.
So he is like Dr. West's like mentee, when you say.
Wait, I thought that was me.
Oh.
Okay.
All right.
I guess it's not. That was tough.
You're number one. He's number 2.
Okay, thank you.
But so he is doing a lot of research in BFR. So we had him on like October 2021. And so we'll post all that stuff too, and we'll send you the episode. But he's fantastic. And even since we've had him on, he's like started further studies. And he's specifically, because of their relationship with the Nationals, he's done a lot in upper extremity. So let's dive a little bit deeper. Yoni, tell us a little bit more about like what you're doing for shoulder rehab with BFR.
Yeah, I want to get that tourniquet on them as soon as possible. It's been pretty amazing to watch doctors who are so involved in literature, and all of a sudden I'm getting scripts that are requesting BFR and things like that, which is great to see that it's permeating your world. I get the cuff on them as soon as possible. We know that if you're not going to be able to load the tissue, at the very least, you are going to decrease how much atrophy transpires by just getting the cuff on. They don't even have to move. Okay, and you're starting to see this in the English Premier League a lot, and it's starting to seep into the NFL, where they're beginning to use cuffs bilaterally in season during travel as recovery, things like that. And the reason that is because it's going to decrease atrophy simply by sitting on a plane and pumping that thing up to 50% and letting it cycle through 5-minute clips. So I want to get the cuff on as soon as possible. Also, the market for blood flow restriction tourniquets has expanded drastically, and so I will educate my patients to buy them at home so that they can. Awesome, and so they can use them at home while they're sitting around watching TV. It's not the most comfortable thing in the world, but it is such a significant difference. An athlete that I texted you about, Dr. Bassett, who had a patellar ORIF, he spent the first 6 weeks when he was non-weight bearing doing an hour and a half a day of BFR. When I saw him 8 weeks post-op, his quad sizes were the same, which is insane. And there's nothing else to pin that to other than the fact that he's a lunatic with his blood flow restriction.
I know. I'm curious. Can you say which one you generally recommend to people?
Yep. I use smart cuffs or H2 cuffs. Either one. I don't have a H2. It's called. I don't have a preference. I will say I remember when I bought my first Delphi unit, which is like the Cadillac. It costs more than my car. And now these things cost like $400.
$400. Yeah.
Yep.
So we have smart tools in my clinic. Ashley and some of our listeners probably know this. I bought it as Christmas presents for my nieces because they both tore their ACL.
Sick. Awesome.
I always liked it, but because where I trained into my fellowship in Vail, they were using it and they were a little bit ahead of the curve that I think when I first came to Denver, the therapists, a lot of them just hadn't had the training yet, or their clinics hadn't invested in it. But over the last decade, like it's really it's pretty routinely available. But I will say I saw a huge, difference with my niece who's been out from her ACL for about 2 years now, just like her quad return and like her strength. She just got beefy so quickly because she was so dedicated to it, and it's what Santa brought her, but it just,
it's awesome.
But I do think it helps a lot.
Well, Yoni, that's so awesome to hear that you want to get the cuff on as soon as possible, because I think that's really beneficial. I try to start BFR for lower extremity as soon as possible. I know there were some questions in our literature about, do you wait for the incision to heal? What do you do for skeletally immature patients? But we know it's not 100% occlusion, and that people do well with this earlier you get it on. And with the upper extremity, you're more thinking it's the growth factor release and the systemic effects that is leading to the proximal gains. So it's not even like you have to work out the shoulder. You can just put it on and occlude. So would you say that you're starting it, like say the patient comes in the day after surgery, would you start it that early? Even if there's swelling, you'd still put it on?
I mean, you always gotta say that you gotta read the room. So if I have a patient that comes in that is absolutely terrified and is just not going to do well, like I'm always making sure that I get to visit two, right? So they come and visit one, they're terrified, they haven't met me yet, and I put a tourniquet on their arm, and I'm like, yeah, just lay here. Like they're not coming back. But patients that I know, patients that I think are just a little bit more grit to them. Yes, I'm definitely trying to do it. We know it doesn't increase edema. We know it doesn't increase infection rates. We know it's not putting excessive strain on whatever it is you guys repaired. So I just don't see the negative. I had this conversation with Dr. Galata, and after the conversation, he was like, yeah, I guess that makes sense. Like, why are we not doing it? But I say the same thing with ACLs, that you guys coming before they wake up, you do more to their knee than I'm going to do in the first 3 to 4 weeks, right? Like you slam it into flexion, you pull it all the way into extension, you make so what am I going to do that you guys haven't already done? So yeah, I would be totally behind it and trying to get it on them as quick as possible.
Yeah.
Awesome.
Yeah, I think all of those things are true. And so our next paper did look at the BFR training program in military cadets that underwent shoulder stabilization surgery. They started at 6 weeks. Ashley touched on like a little bit of like, when do you start? And it seems like there's never a reason to like wait till 6 weeks. Is there anything that you can think of that would make you halt?
There's really not. And what's nice is like once physicians kind of get behind it, read through some of the literature, at least enough to get comfortable with it, I'm not getting questions from docs around it other than, can you please use BFR? So no, I'm not concerned. I mean, my concerns would be swelling. If I didn't read the literature, that's not a concern. Infection rates. And then any type of adverse pressure I would put on the repair, and that's just not there. I don't know what else to worry about.
Yeah.
So about that, so you're saying you don't worry about all those things, but are there any contraindications that would make you not use BFR in someone? So not any of those things that have been disproven in the literature, but certain patient factors besides them being afraid of you that would make you not put on the BFR cup.
Yeah, I mean, I'd be worried if they had some clotting issues. I'd be worried. I'm always leery about first trimester of pregnancy, although it doesn't show up in the literature as an issue. I just want to be careful with that population, kind of explain them and get their buy-in. And that's really it. I can't think of anything else that would really make me nervous.
Yeah. No, agree. Like I don't really have anything like the only time I have not to use it is with the bear. So the bear ACL, just the folks that are, basically Mioc, the company that put that out, their lead scientist has asked that we don't, just as they're still like in their, first decade of patient data, and they're just trying to limit the factors. I think of like, if we have any issues, we want to be able to figure out what they are. So I'm just respectful of that request. But I think most of us that do the bear procedure are also just like, I'm sure at some point that'll get lifted, and because we can't really physiologically sort of come up with a reason why it's not okay. But I'm just respectful of, their scientific sort of protocols for rehab are a little bit, I don't know if Yoni's taken care of a bare ACL yet, but like, it's just a different. Yeah. So just stick with it. I always sort of I don't think everybody does. Some surgeons sort of make their own, but I think I'm just sticking with what they ask for now.
I mean, I think that makes total sense. It's like whenever I have a student or a new PT, I just try to impart the age-old wisdom of like, don't be a dumbass. Like if your patient is breaking out into sweats and they're dreading this tourniquet, okay, we rehabbed a lot of shoulders before BFR, and they did just fine. I would say the same thing for dry needling. Yeah, not for everyone.
So true. I know I've had some people who are like, so I have physical therapists in my office, just like Monday, Wednesday, Friday in the morning. And the primary thing is like just exercise testing. And we do a bunch of like our post-operative exercise testing. And we have like co-treat visits, but we do dry needling and cupping for those kind of people who are like there for their follow-up, but we're noticing they need a little benefit. And there's just sometimes, you can just tell it's like the sweats start to come and we're like, you don't have to do this,
Yeah, just read the room.
Yeah.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the first part of our discussion as much as we did. On the next episode, we'll continue our conversation with Dr. Yoni Rosenblatt and shift our focus to the specific rehab of different stabilization surgeries, then wrap up with a discussion on return to play. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We love your feedback. Hey there, fellow surgeons. It's Dr. Ashley Bassett
and Dr. Catherine Logan. We're thrilled to share what we think is the next frontier in orthopedics with you.
Absolutely. In our sports medicine practice, we're always looking for innovative ways to enhance our patients' recovery journey.
That's right. And that's why we're excited to talk about accelerated recovery, or XR for short. It's a perioperative recovery supplement that's been a game changer for us.
XR is surgeon formulated with clinically researched ingredients at optimal effective doses. It's designed to support wound healing, prevent muscle loss, and speed up return to functional recovery.
Totally, Ashley. And that's where XR comes in. At my clinic, we've implemented the XR nutritional optimization recommendations as part of our standard of care for patients, and the results have been really exciting.
Absolutely. I recognize that our patients' nutritional status has become an increasingly recognized risk factor for surgery. Malnourished patients face risks like delayed wound healing and infections.
Just recently, I had a high-level athlete I operated on who went through a 3-week XR recovery program. The feedback was really exciting. He had faster healing, minimal muscle loss, and overall a smoother recovery process.
And I had a similar experience. The ease of implementation and the positive impact on patient outcomes have been really motivating to continue to study.
And I tried it too. XR is a cranberry lychee drink mix. It's sugar-free and vegan, and it's safe for anyone over 12 years old.
So, fellow surgeons and healthcare providers, if you're looking to elevate your patient's recovery journey, consider XR. Let's embrace the future of targeted nutritional supplementation together.
Visit xrscience.org or xrscience.org to learn more and join us in revolutionizing perioperative care.